is Ken Thomas. I'm an orthopedic surgeon in Anchorage, Alaska. I specialize in lower extremity trauma, limb reconstruction, ring external fixation. I'm pleased to talk to you today about bone transport, indications and approaches. I do have a speakership and product reviewer for Johnson & Johnson DePuy Synthes that I'd like to disclose. This will not have any relevance on our discussion today. And let's talk about why bone transport matters. Segmental bone loss is one of the most difficult problems that we face in orthopedic surgery. There's a high infection burden, poor host and local biology, and limited resources often magnify the challenge. Bone transport is the biological benchmark for these challenging clinical situations in resource limited settings and most other settings around the world, to be honest. The focus of our lecture is not how to do bone transport, but really the indications and approaches. So the when and the why of how to choose bone transport, and also when not to choose it. We'll cover that briefly. The decision making at essence. The technique and constructing a frame and docking will all be covered in subsequent lectures. So our indications, it's really important to look at the whole patient. Every one of these patients is going to have a segmental tibial bone defect. Four variables are going to really determine the suitability for bone transport. These include, but are not limited to, the defect size and exact location, whether it's proximal or distal or mid-diaphyseal. The infection status, have they been infected? Do they continue to be infected? And we'll touch a lot on this, the specific patient biology, what comorbidities they might have, and as demonstrated here in the slide, what is the condition of the soft tissue envelope. So these four variables are really going to drive our decision making, the indications and approaches for bone transport. How big is the bone defect? You'll see multiple ranges published across the literature. They vary widely. But broadly speaking, we tend to break them up into three separate categories. Bone defect sizes that are less than 2 centimeters are suitable for bone transport. That'd be a great first case if you're new to bone transport. Other things that could be considered too are shortening of the limb, bone grafting primarily, or doing a Masquelet-induced membrane. Defects between 2 and 10 centimeters are ideally suited for bone transport. And then larger defects above 10 centimeters or whatever size range you choose to read in the literature are good candidates for bone transport. You could also consider medialization of the fibula or possibly other techniques, amputation being one of them. It's really important to understand that prior infection is an excellent indication for bone transport. After all of the infection is eradicated, thorough debridement is performed, strongly favors distraction osteogenesis. That results in lower recurrence rates of infection than a bone grafting alone, and it avoids placing bone graft in previously contaminated fields. And why is this? It really comes down to how distraction osteogenesis affects the regional metabolism of the limb. Distraction osteogenesis is a powerful technique that increases blood flow, downregulates certain cytokines, increases neoangiogenesis and thus significantly decreases the risk of infection recurrence. As Ilizarov is commonly quoted, infection burns in the fire of regeneration, and regeneration being the new bone that is formed with distraction osteogenesis. Patient biology is very important. Compromised hosts, as it's often referred to in the literature, um, tend to do better with bone transport over isolated bone grafting. Poor nutrition, smoking, diabetes, other medical comorbidities do increase the risk of failure and should be discussed and addressed. But because transport relies on distraction of osteogenesis and the regenerative biology, not the incorporation of graft, it increases the likelihood of success. Cerny Matter gave us the original classification in 1984. This is commonly used. They broke up our patient biology, our so-called host, into three separate groups. Type A host being healthy with a good immune system and good vascular status. This is the patient that we all hope to work on. And so-called type B hosts are compromised, and they can be compromised at the systemic level with medical comorbidities, at the local level with infection, vascular compromise, things like that, or commonly both. And then the so-called C host, where they're really not an operative candidate and the morbidity of treatment is greater than the disease burden. This is their original classification with their patient's host biology cross-referenced with their different local anatomic system for osteomyelitis. And this has been used for decades, and we're all familiar with it. However, in 2026, Cerny Matter is foundational and limited, and we may still use it to talk amongst ourselves. But when you're looking at an actual patient, it's very binary and coarse, and it lumps very different patients into the same bucket, meaning you're either a type A good host, you're a type A candidate for surgery, low complication rate, high rate of success. You're a type C patient where we're not going to operate on you. Or more commonly, what we see are the type B patients. Those are the majority of our patients, and they just get lumped into these buckets. And there's no specific weighting or addressing of different risk factors, whether they can be modified or non-modified. And it really doesn't integrate well with external fixation burden and being in an external fixator for a long period of time, the long reconstruction times, and then the patient's psychological capacity and so-called social capacity, which are very important with transport patients because this is a long process. So what most people have turned to is the modified McPherson classification, and we'll talk more about that in just a couple brief slides. Um, this is their original chart, and it looked at what the infection was like, what the host was like, and what the limb was like. This was originally proposed for total joint arthroplasty infections. However, they then broke down the specific patient risk factors into separate discrete line items. And this is really helpful because now we can look at these, see which ones of them apply to our specific patient, and then more importantly, which one of these can be modified and improved and addressed. Because if we have a patient that, for instance, has low vitamin D or is a smoker, can we supplement their vitamin D or, get them off of tobacco products? That is really going to increase the likelihood of success when we do a bone transport and try to reconstruct their limb. And this is a very key point. And this is one of the things that really everyone needs to look at prior to undertaking a bone transport. And the McPherson classification really allows us to break those things down, look at them in a modifiable way or a non-modifiable way, and then optimize our patient prior to performing the bone transport and reconstructive process. Moving on to soft tissues. Bone transport has a lot of benefits for the soft tissue envelope. Distraction osteogenesis does grow new bone. However, it gives us the ability to shorten areas of the bone and potentially close wounds without the need for rotational or free flaps, which is very powerful. And then we can utilize the osteogenesis to also distract adjacent soft tissues when flaps are unavailable. And this is particularly relevant in resource limited settings. Here you can see a diagram of a patient with a wide open midshaft tibia fracture and associated soft tissue defect. Ring external fixator was utilized to bring the soft tissue defect down together and close it, and then they will undergo distraction, osteogenesis, and bone transport at a different site. Very powerful. In addition, ring external fixation can be utilized with the use of rotational flaps. Here you can see a patient undergoing distraction osteogenesis and having a reverse Searle flap placed over an open bone defect just above the ankle. Busy slide, but a very important slide. When should we not do bone transport? And I won't read through these all. You can look at them at your leisure, but sometimes, and it's rare, but sometimes the limb is just not salvageable. If the soft tissue defects are too great and we can't do a flap and the limb can't be saved, amputation should be strongly considered. If the patient can't follow our instructions or they don't have a strong social support during the limb reconstruction process, that might be another reason to not do it. Severe psychiatric or social barriers as well. And then if they're the classic type C host where the treatment is worse than the disease. But it's important to understand that it's not the best choice for all patients, and there are some significant contraindications. Moving on. In this setting, when we're talking about bone transport, what do we mean by approaches? This isn't a surgical approach. This is more a conceptual approach to bone transport and limb salvage. We basically have one biology, distraction osteogenesis, which is extremely powerful, and then one indispensable tool, highly versatile tool, external fixation. We'll concentrate mostly on ring external fixation. However, as you all know, there are many different types of external fixation. But bringing these two concepts together, our biological tool of distraction osteogenesis and our mechanical tool of ring external fixation, can then lead us to many different approaches to solve this problem. And when we're thinking about how to bring those tools together and define an approach in this sense, we want to look at how big the defect is, how much bone is missing, the exact location within the leg, how the soft tissues look, and what resources we have available to us, and how much experience we have. These are things that we bring together utilizing distraction osteogenesis and external fixation to define our approach. That being said, there are many ways we can move these around and mix them up. Bone transport with ring external fixation is what we'll talk about mostly, but you can also shorten the limb. You can shorten the limb and then re-lengthen. You can do a Masquelet induced membrane, vascularized fibula graft if those resources are available to you. Very technical operation. In addition, medial transport of the fibula utilizing a ring external fixation is very powerful, especially for really large defects. And then amputation. We're going to focus primarily on bone transport with ring external fixation. And we've chosen this because of its power and availability around the world. The classic gold standard is the bifocal bone transport. This is a reliable, versatile, and well-established technique. Very powerful. Lots of patients around the world have been treated with this. The downsides are obviously prolonged time in a ring external fixation and then the pin tract morbidity. One thing that can potentially be used is lengthening over a nail or transporting over a nail. It does reduce the external fixator frame time. It's more expensive. You have an additional implant. It requires an adequate canal, alignment, and appropriate soft tissue coverage. But obviously, it's not something that would be considered with open growth plates in children. And also with the intramedullary device, it may not be the best solution for infection cases, but something to be addressed and acknowledged. How are we going to move the bone? Are we going to do an antegrade bone transport? This is really the gold standard, and the antegrade transport results in better ankle function, fewer complications, and excellent regenerate formation and proximal metaphyseal osteotomy. Retrograde tibial bone transport, this may be required, especially with small proximal segments or very proximal defects. The regenerate bone does tend to grow a little bit slower, takes more time. And then more advanced concepts, if bone transport is going to be utilized for large defects, you can consider doing the so-called trifocal or multi-level transport, where there are two osteotomies and two separate pieces of bone that are moving through the leg to regenerate that defect. It reduces total transport time. It's very technically complex, and it's best reserved for experienced teams who are familiar with bone transport. This isn't easy. The goals are worthy and highly beneficial, but it's not an easy path. Being in an external fixator for a prolonged period of time is difficult on patients. It's difficult for their families. They need to be aware of this. Requires a lot of prolonged care, follow-up, and patient resilience, multiple X-rays, visits to the clinic. That being said, I mean, oral antibiotic suppression is something that could be considered with continued infection. And then amputation, must be discussed honestly and openly as an option, although the lifelong burden of not having a limb is great, as we all know. Someone once said to me, there is no orthopedic condition that can't be made worse with surgery. And I think those are words to remember and not forget. We can make people worse. From a global surgery perspective, bone transport with a ring external fixation is very powerful, and it helps when we don't have microsurgery or free flaps available to us, when bone graft resources are limited, with infection being common, and then with no internal components, those cannot be infected. And if the surgeon expertise exists, but it's not low cost in orthopedic surgeon time, the patient's time, and the significant effort that goes into performing these limb reconstruction surgeries. Practical decision making, If we distill down what we've talked about so far, bone transport is favored when infection is present or likely. The defect is large or growing. If the patient biology is compromised, if we can maximize the modifiable risk factors, some of them we can't change, unfortunately. When the graft volume is limited, if we don't have access to large allograft or ways to harvest large volume of autograft, distraction osteogenesis is highly beneficial. And then when we look for a durable limb, that's our goal. Thank you very much for listening. I'm glad to take any questions or further discussion.